Good afternoon to Nigeria, good morning, good afternoon, and good evening to our teams in the US and all over the world on this call. My name is Maurice Okwe, the Senior SBC Research Advisor on the Agency for All project. This webinar is being hosted for the USAID Agency for All project, and this is our first ever global webinar as a project. So thank you for joining us. You will get to know more about the Agency for All project as the various speakers present. So in the interest of time, I'll proceed to the topic for this webinar, which is confidence, complacency, and convenience. New evidence from Nigeria for tackling vaccine hesitancy. COVID-19 put the world in bondage until the vaccines came. Yet when the vaccines came, some were still hesitant. What made them hesitant, and how do we move from hesitancy to confidence? These are some of the questions we will explore during this webinar. Before I introduce the director for the project, I would like us to observe a few housekeeping rules. Please mute all your microphones unless you have been called to speak. We will be monitoring the chat box for your questions, and our experts will be addressing your questions as we go along. Please note that this webinar will be recorded. We look forward to a lively session together. And now, it is my singular pleasure and honor to introduce to you the Director of the Agency for All project, Dr. Rebecca Longgreen, who will introduce our first speaker. Thank you.
Thank you, Mo. Hi, my name is Rebecca. I am so happy to be with all of you today, wherever you are in the world and whatever time it is. I'd like to give you a very warm welcome on behalf of the Agency for All Consortium to this webinar, seeking to understand, to share our results, which we're seeking to understand COVID-19 vaccination hesitancy. Next slide, please. Agency for All is a centrally funded USAID project that works on research on social and behavior change. So the objectives of our webinar today is really simple. We want to share our research findings with you on COVID-19 vaccination hesitancy, have some time to discuss the implications of this research, and engage all of you in reflection of how we can apply this work to your own research and programming. Next, please. So as I mentioned, we're bringing this webinar to you from Agency for All. And I'm going to do a little bit of introductions, but please, all of you who are online with us, feel free to introduce yourself in the chat box, your name, where you come from, so we can get a sense of who's with us today on this webinar. Next slide, please. The Agency for All Consortium consists of all of the partners that you see here on the slide. So you can see it's a very diverse group of partners with experience and expertise in implementation research, social behavior change, and other kind of human-centered design and other areas that are really important to the kind of work that we do. And they're all come together because we're dedicated to advancing social and behavior change with a focus on agency. The next slide, please. So the goal of the Agency for All project is to really develop local conceptualizations of agency, develop measures to assess agency, and then more importantly, to conduct research to understand how agency is associated or influences health and cross-sector development outcomes, and how agency interventions can support, influence agency and health. Next slide, please. So I wanted to start out, since it is our first webinar, I wanted to invite you all to become engaged with Agency for All. You can join us on LinkedIn, Twitter, or Facebook. Next slide. And you can also sign up here, and I think someone can put the link in the chat also, so you can sign up for our newsletter so you can hear about our research results and the activities and events that we're sponsoring. Next, please. So with that, I'm very excited to introduce our presenters for today. So you can see them on the slide here, pretty much in the order that they'll speak with you. Dr. Nicholas Okoli, the FCT Program Manager on Immunization. Dr. Francine Wood from the University of California at San Diego. Dr. Pompo Colucci from Makerere University, Dr. Lynette Golding from Save the Children, and Dr. Peter Casace, also from Makerere University. And with that, can you go to the next slide? Because I'm thrilled to introduce Foye, our program officer, a program manager specialist on social and behavior change from USAID Nigeria. And she's going to sort of launch us off here with an explanation of the particular project in Nigeria that we are going to share with you today. So over to you, Foye.
Thank you so much, Rebecca, and it's really my pleasure to be here. As I've been introduced, my name is Foye Kerr. I prefer to be called Foye for short. I'm with the USAID in Nigeria, and I'm serving as an activity manager for the Agency for All Buy-in. So I want to take a couple of minutes to talk to you about why we thought this was a great idea to buy into Agency for All. Please move on to the next slide. So I think one thing we will all agree on is how fast-paced the COVID-19 response was. And in a country like Nigeria in particular, a lot of careful considerations needed to go into the kinds of investments that would support vaccine rollout as soon as they became available. And we were clear that these were pretty much a very effective tool for helping to curtail the impact of the project. So USAID had funded a lot of data collection, primary data collection, most of which were hinging on the methodology of telephone surveys through our partner Breakthrough Action. And we had used a lot of those kinds of data that were collected intermittently over time, quick and dirty frequency and bivariate analysis to be able to inform the types of risk communication investments that would help to address the factors that were determinant of vaccine uptake amongst Nigerians. However, at a point in time, on or around the time when we bought into Agency for All, the country experienced a plateau in uptake. There was an initial surge in uptake, and then we started to really see a plateau. And it became really important at that point that we were looking at the data set and making more meaning out of it. By doing a lot of multivariate regression and other types of analysis that would help us to get into and really understand the trends that we were seeing and be more intentional about the shifts we needed to make in our investments and programming. So over to the next slide. So as Rebecca did say earlier on, Agency for All is a global award that seeks to generate a lot of new evidence around agency and what might be influencing that at individual and community and system levels. So what we did. Okay, thanks. So what we did in buying into Agency for All, like I did say, was to procure the expertise to be able to do a lot of the kinds of analysis that would deepen our understanding of the trends and determinants in vaccine uptake and confidence, to better understand how our current investments were shifting the agency in support of uptake of vaccination, but also continue to examine how perceptions are changing, vaccine safety, confidence, and convenience factors, and trust in healthcare providers and the systems that provide them, so that we could immediately adapt and learn and adapt some of our current investments, but also as we look into the future and begin to roll out other new vaccines like the HPV and malaria vaccines, which are also in the works in Nigeria, that we're understanding some of these factors and being more intentional in the way we're supporting them. So next, over to the next slide. So what were the key activities that Agency for All undertook to help us achieve some of the objectives that I've outlined? There was a lot of, first off, stakeholder engagement, local stakeholder engagement to understand, to define a learning agenda, a shared learning agenda. And that then informed a lot of scoping reviews and literature reviews, what's known, what's not known, where are the gaps, what kinds of analysis do people think will be valuable. And so that led into, the second phase of work, which was around the secondary data analysis and collecting, multiple rounds of telephone polling data that we collected between 2021 and the end of 2022 to begin to dig deep into a lot of those trends and variations and shifts across subpopulations and audience segments. And then there was a last phase, which was really just looking at existing messaging campaigns and designing a primary and conducting a primary survey, a primary study that tried to look at message effects and messenger effectiveness and how those were relevant in how we continue to message and how we continue to deploy our risk communication campaigns to encourage vaccine uptake. So I'm really grateful that you are all here today because like Rebecca did say, and then Maurice also alluded to at the beginning, there's going to be a lot of focus on outputs from the secondary data analysis and the message effect and messenger effectiveness study, which we believe as USAID will be very critical learning for everyone who's on the call and people outside of the call as well, to really understand, how we continue to inform, how we continue to intentionally engage. Nigeria remains at about 67% coverage as of, but that varies very greatly by states, with some states still struggling to meet up to 30%. So some of these are very important, even for the COVID vaccination, but more importantly, as we sort of look futuristically at our ongoing vaccine investment in vaccination programming writ large. So thank you again for coming, and I invite you to engage with the findings that will be presented today during the webinar. Thank you so much. Over. I'll hand it over now to Chika.
Hi, everyone. So this is really, really good. So it is my singular honor to introduce the next speaker because he's a message from the field. Okay. His name is Dr. Nicholas Okoli. He's the State Immunization Officer at the FCT, and he has been in the COVID-19 space for a long time. He was also part of the technical working team that focused a lot around vaccine hesitancy, vaccine confidence. All these things will be brought to the fore. Dr. Okoli, I hand over to you.
All right, thank you very much, Chika. Permit me to stand on the already established protocol, and as I've been introduced, my name is Dr. Okoli Nicholas. So I will straight go into the meat of the matter. I will be sharing lessons learned from social and behavioral change approaches for the COVID-19 vaccination campaign. All right. Okay, let me give us a little background introduction. Where the pandemic hit us like a bomb, and there was hope nowhere, and a lot has to be done to make sure that the masses are protected. So the vaccination actually came as a beacon of hope amidst those level of uncertainties that we had. So the vaccination campaign itself, while it emerges as a critical pillar of our collective response in that phase of global health crisis like we had in the COVID-19 pandemic. So, but it is important for us to note that the COVID-19 vaccination itself does not only hold the promise of controlling the spread of the virus, but also symbolizes the beacon of hope amidst the uncertainty, like I've said. However, the success of the vaccination campaign extends beyond the mere distribution of the vaccines. So, can you hear me?
Okay.
Confirm if you can hear me, please.
We can hear you. We can hear you.
All right, thank you very much. Yeah, so I was saying that the success of the vaccination campaign, the COVID-19 vaccination, extends beyond the mere distribution of the vaccines. I said that it delves into the complex realm of human behavior and attitudes. So 2 years down the line, the vaccination rollout started. We've had a lot of challenges, and we have devised means to circumvent the challenges. So I'm here today to share some of those lessons learned, especially when it has to do with social behavioral change approaches towards those COVID-19 vaccinations. We found out that the decisions individuals made regarding the vaccinations were influenced by various factors, including perceptions, fears, and societal norms. Next slide, please. So what are those lessons learned? So let me start, I will give them in some thematic areas. Let's look at tailored messaging. So when it comes to conveying information about the COVID-19 vaccination, one size does not fit all. So the messages have to be tailored based on the target audience. So what works, what fits in the medical community will not fit in the religious community. So the messages have to be tailored to make sure that you are talking what the audience wants to listen to. So you get your audience and you know what to get to tell them. Because when you do that, we find out that the tailored messaging was very important to foster empathy and resonate with the vast audiences and ultimately drive positive actions in the journey towards that widespread vaccination that we've had in Nigeria at large and FCT in particular. So the tailored messaging involved crafting content that resonates with specific cultural and demographic groups, acknowledging their unique perspectives and concerns. So we find out that there are different cultures. There are some cultures that does not take vaccinations. They may take oral medications, but they will not take injectables. So some of them from a religious background. So you really have to get the audience and you have to know what to talk to them. So that's why the next thematic area, the cultural sensitivity and relevance, was also an issue. So the vaccination considers the diverse background, the languages, the traditions of the target audience. So the message we gave was to foster a sense of inclusivity and connection. So you had to let people to know, speak the language that they understand, bring them close to you. If their reason for hesitancy is on religious grounds, then you have to also talk to them from that perspective. And that is also where the credible sources you are using to talk to them matters a lot. So if the challenge they had, like I said, or the reason for their hesitancy had to do with religion, that's not when you're going to bring a medical doctor to talk to them. No, you have to bring somebody from the religious background. You have to bring, if it's in the mosque, you have to bring the imams. If it's in the church, you have to bring a pastor to talk to them from that angle. Then, of course, if the reason for the hesitancy is also based on medical grounds, then that's where you have to bring in healthcare professionals to talk to them. So those are the things that we have to do, and that's why I said that the messages have to be tailored. So again, fact-checking and rapid response. You fact-check the information because a lot of rumors were going out there, and you have to quickly counter those false claims. That was very important because the rumors were also traveling as fast as the virus was traveling. So when the rumors come out, you have to swiftly deal with it, countering those measures. So by addressing those misinformation promptly, so we were able to maintain control over the narrative in our campaigns. So I have said that the use of credible sources, including healthcare professionals and authoritative institutional endorsements, were able to also give us the desired acceptance during the campaign. Next slide, please. So we look at the role of effective communication. And this is exactly where the power of social and behavioral change approaches comes into play. A vaccination campaign is not just about delivering the vaccines, like I said, it's about delivering that message, okay, which we now cuts across a diverse section of the society. So effective communication was very, very important and was very, very essential for us to bridge the gap between the medical science and the public perception. Remember, the Google search is just a search engine, is just a click away. So people go to the search engine and see a lot of things. So, but by the time you deliver effective communication, you'll be able to bridge the gap between what they're saying and what the public perception is. Then most importantly, is also the building the relationships. We didn't just deliver information, we build relationships through campaigns. So our community engagement structure was very robust and was one of the cornerstones for the effective campaign that we had in the FCT in particular. So we had to involve the local stakeholders and get their buy-in, okay, and commitment. So that was able to foster a sense of ownership and partnership with them. So that also helped very well to overcome the hesitancy that we had during the campaign. Of course, I've said that misinformation spreads as widely as the virus itself, as rapidly as the virus itself in this digital age. So addressing misinformation was very, very important, and also addressing them real time. So any false claims that goes out there, remember when the vaccination came out initially, there are a lot of claims about the vaccine being able to alter your DNA, being able to cause sterility, being able to generate electricity, use it to power your electric bulbs and a lot of things. So you have to quickly counter those false claims real time, and we're able to do that so that we maintain the control over the narrative, like I said. So that was very important for us to do that. Then the last but not the least is the online and offline strategies. So we were also able to not just social media campaigns and informative pamphlets, IAC materials, and engaging public service announcements. So it was a multi-pronged approach, was very essential. So what works in community A might not be able to work in community B. So we have some hard to reach areas, we have some underserved population in the FCT that you didn't need to reach to them through the online strategies. You have to go offline, you have to go to them and talk to them in their locality, in their local languages, and get their buy-in. So those were the approaches that we were able to use, and we were able to get to where we are. It's not yet Uhuru, but I can say that we have been able to a greater percentage overcome the hesitancy that followed the deployment of the COVID-19 vaccination in FCT. All right, so I think that's all for me from now. The next slide is the field experiences, people in the community, talking to them, taking the vaccine to where the people live and work, and making sure the vaccine gets to them, and using their community members to also deliver the vaccination was a good strategy that we used. Thank you, and over from me.
Wow, it is quite interesting and quite elucidating. A lot of work has really gone into moving from hesitancy to confidence. So thank you, Dr. Okoli. Very well said. Thank you very much.
Thank you, Chika.
So we're going to go to the, thank you, yes. We're going to go to the next speaker. Very Francine Wood. The ball is now in your court. Over. She'll be talking about a secondary data analysis on factors affecting vaccine. Francine, over to you.
Thank you very much, Chika. So on behalf of the project team, it's my pleasure to present the findings from our secondary data analysis on the factors affecting vaccine uptake in Nigeria. Next slide, please. So this study sought to understand drivers of COVID-19 vaccination. And research has shown that hesitancy, which is the delay in acceptance or refusal of vaccines despite its availability, impedes the progress of vaccination uptake. So as Foye mentioned, COVID-19 vaccination uptake has a lot of room for improvement. And in the most recent data published by the Nigerian Center for Disease Control, in 16 states and the Federal Capital Territory, less than 60% of eligible Nigerians were fully vaccinated. And in only 6 states, 100% of eligible vaccines were fully vaccinated. And so our study really sought to further inform COVID-19 messaging that seeks to improve vaccine acceptance. Next slide, please. Our analysis used data from Breakthrough's Action Telephone Polling Survey. The data was collected at 8 time points. However, we analyzed only the nationally representative rounds, which were measured at 4 time points. Our study and analysis were informed by the 3C model, which is vaccine complacency, confidence, and convenience, as well as ideational theory. And we'll get into that a little bit later. Next slide, please. So we're going to, next slide, please. We're going to start off with sharing some findings from each of our research objectives. So the first objective focused on the relative contributions of the 3Cs to hesitancy. On this next slide, we will delve into vaccine uptake across the survey rounds before talking about the 3Cs. So as we noticed from the graph, vaccine uptake increased over time, and it had the largest relative improvement over time. Over time, I'm referring to from November 2021 to August 2022. The remaining of our sample were unvaccinated, and they shared their vaccine intention. So they told us whether they wanted to get vaccinated immediately at a later time, or if they were unsure and had no intention to get vaccinated. And we can describe these unvaccinated respondents as vaccine hesitant respondents. And overall, we noticed that the percentage of unvaccinated respondents decreased over time, regardless of their intention. And of the unvaccinated groups, the largest relative reduction from November to August was among those who were unsure and had no intentions of getting vaccinated. And the smallest relative reduction was among those who reported they would get vaccinated at a later time. So our overall key message is that there are positive shifts. We saw that vaccination increased as hesitancy decreased. Next slide, please. We assessed the change in the 3Cs from November 2021 to August 2022. And as mentioned previously, the 3Cs refer to the levels of confidence, complacency, and convenience, which are defined on the left on this slide. Vaccine acceptors tend to be confident. They have low or no complacency, and have access to vaccines. So overall, in the data that we analyzed, we found a positive shift in the 3Cs with improvements in levels of confidence, convenience, and reductions in levels of complacency. We disaggregated the sample by vaccination status, and we found that regardless of the survey round, unvaccinated had higher levels of complacency and lower levels of confidence, as well as lower levels of convenience. And this difference shows that there is a lot of work, there is some work that needs to be done to bring the unvaccinated respondents up to vaccine acceptors. Next slide, please. To further understand the relative roles of the 3Cs to vaccine hesitancy, we conducted some analysis to really understand how do these 3Cs contribute to hesitancy. And our findings suggest that complacency was the largest factor influencing hesitancy and increased by 10 percentage points from November to August. Respondents concerned with accessing vaccine diminished over time, and that confidence's contribution was moderate and remained stable over time. And so these findings underscore the importance of the 3Cs when we want to promote vaccine acceptance. Next slide, please. We sought to understand factors associated with the 3Cs and conducted some Poisson regression models analysis. So on this slide, we see forest plots showing the results of our regressions, and we are only focused and are presenting on this slide the significant findings. Our results suggest that people who report ease of access to COVID-19 vaccines felt that the wait times were appropriate at vaccine centers and had confidence in the health workers' competency. had higher confidence and convenience and lower complacency. And so when we think about this from a programmatic perspective, it shows the importance of making sure access to vaccine is easy for our eligible population, wait times aren't long, and that we are improving the health workers' capacity so that people have confidence in their ability to give vaccines, so that we can improve levels of confidence and convenience and reduce complacency. We also looked at media exposure. It was largely unrelated to convenience, the 3 C's, and TV exposure had no significant associations. But interestingly, we found that people who listen to the radio daily tended to have higher confidence and lower complacency, which shows there is maybe some opportunity to capitalize on that. Next slide, please. So our second research objective was to characterize the changes in vaccine hesitance segments over time. And for this analysis, we restricted to the last 2 rounds. Our segments were informed by the Johnson & Johnson existing segmentation process. We characterized our respondents into groups based on the adherence to COVID-19 prevention practices, their vaccination attitudes, beliefs, and perceived norms. So on the slide, you see the segments that we produced. We had 5 segments: enthusiasts, pragmatists, ambivalent, skeptics, and cynics. Overall, we found promising trends with reductions in the percentages of enthusiasts, ambivalent, cynics, and skeptics. And of these 4 where we found reductions, the smallest relative reduction was seen among cynics and ambivalents. And so this may indicate that these segments are harder to shift. And the percentage of pragmatics improved over time. And so this is from May to August. Next slide, please. Our third and final research objective was to analyze the trends in ideation and their effects on hesitancy. And we also restricted this analysis to the last 2 nationally representative rounds in May and August. Next slide, please. So ideation theory posits that an individual's beliefs, values, and attitudes about COVID-19 vaccination influences their vaccine uptake. And so if a person has positive perceptions about ideation, they may get vaccinated. We assessed ideation as a score ranging from 0 to 9, and it consisted of 9 items about the respondents' beliefs and attitudes towards COVID-19. And so as we see in the graph on the left, ideation levels were moderate. It improved from May to August. And we noted that ideation was higher among the vaccinated than the unvaccinated. And just to note that the relative improvements were about the same for both groups. Further analysis within the unvaccinated or the hesitant respondents show that the levels of ideation increased for almost all subgroups. There were 2 that we saw that ideation levels decreased. So the Northwest regional residents, as well as older respondents, and older respondents who are 61 years and older. So the differences in the trends in the subpopulations highlight that the need to understand the different audiences in which we work in, because the one-size-fits-all approaches don't necessarily work, as Dr. Oliki mentioned previously. Next slide, please. So overall, what does an analysis show us? It shows that in the data set that we analyzed from the Nigeria NOI polls, there were positive shifts in 3 C's. As confidence and convenience increased, complacency reduced. Complacency was the largest factor influencing vaccine hesitancy, and its relative importance as a barrier to vaccination grew over time. We found out positive ideation was associated with reductions in hesitancy, as the theory suggests, and that vaccine hesitant segments have distinct profiles and specific challenges dealing with vaccine hesitancy. And so all these findings really further emphasize the lesson learned shared by Dr. Okoli, that really is a need for strategic and tailored messaging, as well as interventions that address the specific concerns and barriers that individuals deal with, and that a one-size-fits-all approach doesn't work. And so I think I'm going to stop here. Thank you very much. I'll be happy to answer any questions you may have in the chat or during the Q&A sessions. I will now hand over to Paul, who will talk about the message effects and messenger effectiveness study.
Thank you very much, Francine. I'll take it over from there to now introduce another study that we did that was looking at exploring the role of in the COVID-19 vaccination communication in Nigeria. And as I move on, I want to really acknowledge the contribution of our colleagues from Breakthrough Action, the great collaboration that we have had in working together on both the secondary data analysis, but also on exploring message effects and messenger effectiveness. Thank you so much. And you are welcome. I see many of you on the call. You are indeed welcome. So we know that vaccination is highly effective as a public health intervention. And so understanding vaccination barriers and facilitators is key to effective risk communication and community engagement. So this particular underscores why we felt it is important. This is an important issue to study. And the Agency for All conducted research in the Federal Capital Territory, what we call FCT, and the Cross River State in Nigeria. And the focus was on two components. The first component was on the message effects. And basically here we wanted to understand what is the relationship between messaging or campaigns and empowerment. And then we also wanted to understand what are the most effective COVID-19 vaccination messages. Apart from that, the second component, which was on messenger effectiveness, here the interesting question we wanted to understand was, does changing local messengers affect vaccination intention? So that this was the core, is at the core of what we are going to share. Next slide. And the objectives then were to deepen understanding of how messaging can influence different elements of empowerment, and these relate a lot to agency, like a critical consciousness, goal setting, conviction, but also we know that there is a nexus between agents and social norms, so we explored that to see how these then drive behavior change regarding vaccination. We also wanted to gain insights into whether campaigns like the Follow Who Know Road can increase agents at individual and family levels, and if it does, why and how? So we wanted to have an appreciation of this, but beyond that, we also wanted to test whether local relevance influences messaging efficacy. Next slide. And now I hand over to Lynette to take it from here. Thank you.
Thank you, Paul. And thanks everyone for joining us. If you could go to the next slide. So for the message effect study, we had two objectives. And specifically for this arm of the study, we were interested in a nuanced examination of the role that agency and empowerment play in COVID-19 vaccination uptake. Also the pathways of decisions that lead to vaccine hesitancy or acceptance, and also the dynamic and contextual nature of COVID-19 vaccine hesitancy, really examining the relationship between agency as a component of empowerment and getting vaccinated. Next slide, please. As Paul mentioned, we were interested in looking at campaigns like Follow Who Know Road. The Follow Who Know Road campaign was developed by Breakthrough Action Nigeria to promote COVID-19 vaccination uptake to the general population in Nigeria, in particular in 9 states where the vaccination levels are low or were low. The campaign included social media messages, an entertainment, education, radio, and television series, and also community mobilization activities. The campaign began in August of 2022 and ran until this year, June 2023, when the 9th and final spot was aired. Next slide, please. So we held a total of 4 participatory workshops, 2 in Abuja and 2 in Calabar in Cross River State. The participants were recruited through purposive and snowball sampling from the Nigerian general population. The activities for the participatory workshops consisted of 3 activities. 1, projective storytelling and role playing. We decided to use these activities because they provide a visual and non-threatening way to explore experiences, feelings, and beliefs around agency as it relates to getting vaccinated. And specifically, we wanted to gain insights into what getting vaccinated involves, including what leads a person to decide to get vaccinated or not, and to help identify what choices people have and the factors that affect those choices. Also, participants were shown all 9 of the Follow Who Know Road videos during the participatory workshops. The reason that we showed these, the Follow Who Know Road videos, is because we wanted to prime the participants before the role-playing activity with an example of people like them modeling goal setting and conviction and critical consciousness, knowledge, and social norms. Next slide, please. The qualitative data from the participatory workshops were analyzed using a content analysis approach. The goal was to really examine the occurrence of selected explicit and implicit terms and themes arising from the data. Next slide, please. So here you can see our research question, the one of them, can messaging contribute to individual and family agency and drive behavior change regarding vaccination? And we're saying yes, perhaps. And that's because our sample size was small and the findings may not be generalizable to other contexts or other populations. That said, agency, it involves individuals or groups being aware of their ability to make choices, setting individual or collective goals, and taking action to reach those goals. Choice, goal, and action appeared in all narratives that were developed as part of the projective storytelling activity. And this isn't surprising because all the participants were primed for this activity with the definition of agency and empowerment, and were asked to explore experiences, feelings, and beliefs around agency and empowerment as it relates to a time when they decided to get vaccinated or get a family member or child vaccinated. Agency was less reflected in the role plays, and this makes sense given that the participants were primed with the Follow Who Know Road videos before developing their role plays, and the Follow Who Know Road campaign materials were developed using the 3 C's model. The Follow Who Know Road campaign was not focused on agency, but rather the edutainment and the social media aimed to increase confidence and reduce complacency to getting vaccinated. However, confidence and complacency were minimally mentioned in the content analysis of the narratives for the role plays, so that was interesting. Now, a central story arc in the majority of the narratives the participants developed revolved around a friend or a family member or a healthcare worker providing information about the COVID-19 vaccine, and that individually rationally acting on that information and deciding to get vaccinated. In such narratives, the individual who was initially hesitant but then decided to get vaccinated often displayed enthusiasm to be vaccinated and a sense of confidence or satisfaction with their decision. Salient factors such as social support, self-efficacy, social norms, aspiration, setting self-determined goal, awareness of the opportunity to be vaccinated for COVID-19, and also consciousness of choice related to agency and empowerment appeared in most of the narratives, both from the projective storytelling and the role-playing. And this not only suggests their importance, but also their relevance to the decision to get vaccinated. Next slide, please. So we're saying yes, perhaps again, to this different research question. Can a campaign like Follow Who No Road increase vaccine-related agency at the individual and family levels? If so, why and how? So yes, perhaps. The findings suggest that edutainment can help build consciousness of choice and self-efficacy to take certain actions, enabling individuals to achieve their self-determined goals within the opportunities and constraints of social norms. Approximately half of all workshop participants from both states felt that the videos, like the ones that are part of the Follow Who No Road campaign, could influence their desire and their decision to get vaccinated. And participants really appreciated that the videos portrayed how individuals can make informed decisions and take actions that align with their goals and values regarding vaccination. So it seems that future campaigns should consider employing a similar approach. Now, participants did, however, state that they wish the videos included information on the possible side effects of the COVID-19 vaccine. This makes sense given that the fear and the skepticism about vaccine safety were major themes in the narratives produced through projective storytelling and role plays, and one of the main reasons cited for vaccine hesitancy. It should also be noted that there was a difference between the participants' perceptions of the Follow Who No Road videos. Notably, the participants from Abuja seemed more accepting of the Follow Who No Road videos than the participants from Calabar. Moreover, the participants from Calabar suggested that the characters portrayed in the Follow Who No Road videos did not resemble people of Muslim faith, nor were the videos realistic to their context. So, Calabar is predominantly a Christian region, and the participants in both workshops in Calabar were representative of the population demographics of the state. So it could be that the participants were practicing religious tolerance and considering how Muslims would react to the videos. However, this anomaly was not investigated further during the workshops. So I'm going to turn it over now to you, Peter, to take us through the messenger effectiveness study portion of this, or sorry, the messenger effectiveness portion of the study. Over to you.
Thank you very much, Lynette. So as previous speakers have spoken, so the second component of the study was messenger effectiveness. Next slide, please. So the messenger effectiveness component aimed to test whether local relevance influences messaging efficacy. Next slide, please. So in total, we targeted 480 people, respondents, and I need to mention that this was an intercept survey that was conducted on 2 major market days, mostly on Friday and Saturday, in the 2 states, FCT and Cross River. So in each of the states, we targeted 4 major markets to reach the respondents. Next slide, please. Yeah, so this was an experimental study design. And in terms of measuring messenger effectiveness, we considered quite a number of questions. The first question is, do you believe the person or organization delivering the message? In your opinion, is this person an expert on whether you should be vaccinated? And the third question, how much do you trust the person, organization delivering the message? So we came up with a summative score where that was ranging from 0 to 3, where 0 was the least effective and 3 was the most effective. In addition, we asked all the respondents whether they would share the message with their family or friends. So in terms of the sources of information, we had NCDC/WHO, the APROCO doctor, nurse from a public health clinic, and a combination of these sources, the NCDC/WHO and APROCO doctor, and the NCDC/WHO and the nurse. Next slide, please. Yes. So in terms of the effectiveness of the messengers, we noticed from the data that, overall, a nurse was the most effective source of information. And, it was the same case when it came to FCT, but for the case of Cross River, it was a combination of NCDC/WHO and the nurse. In terms of the least effective source of information, APROCO doctor emerged to be the least effective, and this was in both Cross River State and FCT. Next slide, please. Yeah, so we assessed each of these questions. The first question, do you believe the person, organization driven the message? And the results tell us that, slightly more than half of them say yes, with, NCDC/WHO, emerging, having a high score, while APROCO doctor had the least, score. Next slide, please. Next slide, please. In your opinion, is the person an expert on whether they should be vaccinated? Again, so we noticed that a nurse, had the highest score with 88%, or compared to the APROCO doctor who had the least, which is slightly under half, 48. Next slide. So again, how much do you trust the person, organization during the message? We noticed that, the nurse and NCDC/WHO and nurse had the same proportion, talking about 71% vis-a-vis the APROCO doctor with the least, which is 45. Next slide, please. So we also assess the relationship between willingness to share the message and the source of message. What the results tell us is that, the willingness to share the message was significantly more likely if the message was coming from, NCDC/WHO. But I have to mention here that, we controlled for other variables like social demographic variables, media habits, and vaccination intentions. When you look at other sources of information, they were not significant. So it's only the NCDC/WHO was significant. And in this model, we made the APROCO doctor the reference category because it had the least score. Next slide, please. So, the summary of the findings. So the first, key finding is that nurses from a public health facility was considered to be, the most effective, whereas the APROCO doctor was considered to be the least effective. But what we also note from the data is that willingness to share COVID-19 messages could have been influenced by other factors other than the message source. Thank you very much. I hand over to Paul.
Thank you, Peter. And now I will take us through the key takeaway messages from the two components of the study that have been very well presented. Next slide. So the four key takeaways here. One, that the locally relevant messaging plays an important role in influencing decisions on COVID-19 vaccination. So the local relevance of the message being believed and sort of speaking to the context is important. And then the other key message is that COVID-19 vaccine uptake is largely driven by locally relevant messages that are context specific. So context specificity, in addition to local relevance of the message, is extremely important as we move forward. This is a key lesson learned. And then the use of multiple channels and entertainment approaches are important. So no one channel, but choosing channels that can reach and meet the different needs of our target population is extremely important, of course, including aspects of audience segmentation here. And the other lesson learned is that interpersonal communication strategies are extremely important, particularly in building trust and credibility. So thank you, and I hand over to Foye to talk through what the findings of the study mean, with all these results, what are the implications for programming? Thank you.
Thank you so much, Paul, and I hope you can all hear me. So thank you again for the presentations, and I think a big shout out to all of the presenters for walking us through the findings from both the secondary data analysis and those from the message effect and message effectiveness studies. I think it's been quite exciting and interesting to listen to all of the nuances from the findings. Really quickly, in terms of thinking about the implications of of these studies, I think the first thing that I would say is that the data did suggest a lot of convenience being a critical factor in vaccine uptake. And as convenience factors shifted, because Nigeria deployed a very big mobile campaign approach where vaccines, like Dr. Okoli said, were taken to exactly where people were living, working, worshiping, and playing and praying and converting. That those convenience factors, as more of those convenience factors got addressed, that vaccine uptake improved. Shifts away from the one of the campaign mode and begins to think about integration of COVID vaccines into routine immunization and primary healthcare services, that we're paying close attention to convenience factors, not just for the clients, but also for the providers that are going to be providing them. And I think, by integrating and increasing the, touch points and reducing the missed opportunities for introducing the vaccines to clients who are already engaging with the health system, and perhaps even through the outreaches for those who are not engaging with the health system more directly, then, potentially that could also help with the complacency factors that the research also found to be the significant contributor to vaccine hesitancy. So when people are addressed based on the original intention for which they're engaging the health services, and you're integrating and layering on COVID vaccination as an additional services, you potentially are better able to address their needs holistically and be able to layer on what they care about to introduce something that they may not care as much about. I think the other thing for me also is the secondary data analysis and the study all seem to validate healthcare workers as a trusted source of information. And they're also going to be the primary channel upon which our integration and delivery through integrated approach is going to be hinged. So I think it also just begs the question and the need for programming and investments to shift in ways that also support the healthcare workers to better deliver on their role. First, as an audience, because they also have their own questions, they have their own concerns, and two, around their competencies and skills in ways that allow them to, have empathetic and trust-building conversations with clients to increase confidence in vaccine, and ways that also help them to address their own concerns, about another, layer of services being integrated within an already, burdened primary healthcare system. Unfortunately, most of our investments through Breakthrough Action have resulted in a lot of tools that help healthcare workers feel equipped. So I think here is the point to, the takeaway would be to really think about how to scale up some of those, the adoption of some of those excellent tools that have already been created. I think finally for me would be, before I pass over to Julian, would be, we did hear a lot about, from the messenger effectiveness, for example, about healthcare workers, local nurses being a trusted source of information. So I think going forward as well with campaigns, with messaging campaigns that seek to enhance vaccination uptake, it will be very critical and important to think about how we amplify in ways that are most relevant to people, and sort of increasing that local relevance of messaging that Paul spoke to. And I think at this point, I'll hand it over to Julian for her reactions as well.
Thank you, Foye. I really appreciate all of this work, and I think that in terms of, beyond the implications of this research, even beyond COVID, beyond Nigeria, I think that what we find is that, there's encouraging results in this research, that you can use really good social behavior change programming to influence behavior around issues of vaccination. I think that, speaking from a global perspective, there has been some sort of, skepticism itself of like, well, if there are these, if there's distrust, if there's complacency, what can we do in the face of this? And I think that this research demonstrates you can be effective in sort of, even with messaging and some of the information campaigns, to shift some of this, but also recognizing that pragmatic improvements, so really working at sort of making pragmatic, incremental changes to make behavior change easier for individuals is critical. In terms of agency for all and like increasing agency and that self-efficacy point as well, I think that we find encouraging results here that, you can use social behavior change programming to influence individual self-efficacy, that I can, act on sort of intentions and move from intention to action. Agency for All is engaged in numerous research activities across the world. One of the things that Agency for All is using some of these frameworks of vaccine hesitancy, this 3C, complacency network, is to look at it in other sort of health areas. So Agency for All is doing research on contraceptive hesitancy and looking at, can we adopt that vaccine hesitancy framework and framing into other health areas like reproductive health? And so I think that the findings that we have from Nigeria will be applicable and, give this sort of shared learning in a global sphere. So I think that, I really want to recognize Foye's leadership in sort of designing this research agenda and, and engaging Agency for All to ask these really critical research questions. And I think that we'll find applicability across many different areas. So with that, I'm going to hand it back over to Paul. And I know that there are some questions in the chat or in the Q&A, so I do want to give time and space for that. But thank you again, everybody, for this excellent work and presentation. Over to you, Paul.
Thank you very much, Foye and Julian, for those remarks about the programmatic implications for the results. And that is a very good transition into now giving a chance to our audience to ask questions, clarifications, to make comments. And I know that in the chat, there have been a number of questions, and I've seen that there has been a lot of engagement by my colleagues with those questions. But please, if anyone wants to ask any further questions, you can put that in the chat, or we could allow you to speak. So you just put up you raise your hand using the relevant symbols or symbolism, and then you should be able to speak. We have about 15 minutes to do that. So please, this is your time and this is your chance. Take your best shot. Thank you. So, for example, there is a question I see in the chat on as a messenger, a Aproko doctor was assessed on his capacity to make audience. I think the question is, was Aproko doctor assessed on the capacity to make audience convert intentions to action? Somebody is wondering if there was an assessment on the reach of the Aproko doctor, and if people could actually and if people could actually, learn something more about that. Does anyone want to take on that question? And I see Lotus is engaging with this question through writing, but feel free to also answer that and speak. Let's see if there are some other questions. I see another question that we need to answer on this finding reaffirmed the experience we were having at the field while implementing COVID-19 vaccination exercise. I think that is good. It is only confirming the results of the study. Chika, I see Chika, you have raised your hand. Do you want to go ahead and speak?
Yes, I wanted to answer one of the questions concerning Aproko Doctor. So Aproko Doctor has over 2.2 million followers on Facebook and on Twitter. So for social media, he's actually apt. And apart from that, he's a doctor and then speaks the local language that is easy for people to understand. So Aproko Doctor is actually one of the kind of influencer that will be apt for this kind of research. Seeing that for this for the secondary data analysis, because he has the reach, he has the capacity, and people follow him a lot. So I just wanted to put that on the table. Over.
Thank you very much, Chika. I see another one from Olympus at the Banjo. What is your feeling about masking the reportage on Aproko Doctor as private health influencer instead of how it is currently reported? Do you want to take that, Chika, again? Because it is also an Aproko Doctor.
Okay, so I didn't get the question. What was the question?
What is your feeling about masking the reportage on Aproko Doctor as private health influencer instead of how it is currently reported?
Okay, so how is it currently reported? He's a great influencer. So we measured the media use, and then there was a lot of analytics to check his capacity and his reach. Because we are talking about social media, you have to get someone who has the reach. So when he does his live chats, how many people join in? When he's on Twitter or on Facebook, do people believe what he does? And then he uses all the various social media platforms. And then he sends the message. Apart from that, he's a medical doctor. And he sends the message in the language that the citizens can speak to, they can understand. It simplifies the communication in such a way. So, Aproko Doctor.
That is good, Chika, but it might also be good for Olympus to ask this question again, if you can.
Foye's hand is up, so she can answer that. Foye.
No, thanks, Chika, and thanks, Paul, and thanks a lot, Olympus, for that question. I mean, I think I hear the thinking or rationale behind Olympus's question, which is less around, what we found, but more about how we're reporting by specifying the name of the social media influencer that, was assessed as part of the messaging campaign. So I hear you. I think, that's probably something that we can also take away from here is potentially for the final report on a more global audience being a bit less specific about his name, because I think I hear what you're, I think I kind of reckon with some of the reasons why you might be raising this concern. So thank you. Over.
Thank you. And then there is an interesting question about the choice of FCT and the Calabar, and Peter is going to take that.
Yeah, so thank you very much for that question. So we considered, quite a number of reasons as to why we, went to FCT and Calabar. One of them, was, the low uptake of vaccination. So we, low rates of vaccination. So we thought we would, consider these two states. The other reason was about, the ease, but also, in getting IRB approval. So that was, one of the other reasons. but also security, so we also considered an element of security, to allow, the field teams to collect data, and also, complete all the data collection exercise. Thank you.
Thank you, Peter. I see another question, and I encourage participants, if you would like to speak to the question, you go ahead. For example, I see this is an anonymous participant, so I can, that isn't really clear. That isn't really clear to me. I know a lot of people that are not educated, and convincing them is a little hard, as a lot of them believe the West has influenced me against the traditional beliefs I grew up with. So I'm not sure if Lynette, you want to say something about this one, or Chika?
I can also start with that one, Paul, because I think that was directed at one of my previous responses. So that's a really important point. Thank you for raising it. This is a huge factor that's represented in the 3Cs. In this case, particularly confidence. And that was one of the main intentions of this study, was to look at what sorts of locally relevant messages and messengers could be used to convey COVID-19 messaging, so that it's not necessarily somebody coming in from an external community, from the West, from some sort of an organization that may not have particular relevance or salience within a given community, but that these messages are designed in a participatory way that engages communities, so that they are coming from and with these communities rather than being directed at these communities. So we absolutely recognize that this is a huge, huge barrier to vaccine uptake in many parts of the world, including Nigeria. And that was one of the main intentions of this study as we set out. Thank you.
Thank you. I see another question about from Emmanuel. Emmanuel, do you want to speak to this paragraph? I think it has very useful content. Please, do you want to speak to this, Emmanuel? You can unmute and go ahead. If not, I will go ahead and read it, but if you can, go ahead.
All right, thank you very much. This is just to appreciate the team, the research team, and everyone. I really appreciate the findings. And I just want to say that, just like stated, it's been a pleasure working with the FCT Primary Healthcare Board and all other stakeholders in FCT to improve the uptake of the vaccine, working to improve acceptance, improve confidence in people within the FCT, and making it more convenient through campaign, taking the services to the people, bridging that accessibility gap, has also been helpful. And very importantly, working with trusted voices, people that are perceived as trusted voices, has been helpful, just has been stated. And such people include the community leaders, the gatekeepers, faith leaders, healthcare workers. And it's also very important, as has been said, engaging with healthcare workers as audience. We also need to look at the healthcare workers' well-being. We also need to look at their capacity to communicate appropriately, and for us not to miss other opportunities, like when clients come to the facilities for other services, the opportunity to present them with messages related to vaccine, and see how they can make up their minds to take up the vaccine as they come to the facilities. Well, so again, I want to appreciate this session and everyone who was part of the research. Thank you very much, and over.
Oh, there was a hand from Mansu, so if you can allow him to ask his question.
Yeah, that is fine. Please go ahead.
And see if you can hear us on mute, and just go ahead with your question, please.
I see some other questions here that we might pay attention to as we wait for her to ask her question. So like there is this question from Chika, which is very interesting. Generally from this research, what really stood out as a factor that can help convert intentions to action? A question related to agency. I know Lotus is writing something, but also Lynette, if you want to say something about that. And then Peter, if you can say something about to what extent can the findings be utilized in other states to mitigate vaccine hesitancy, especially how can these findings be applied in other locations?
Thank you very much for that question. So what I can say is that these results provide context, but we need to take, caution, to overinterpret them, but also to generalize them to other states. Remember that we, visited only 2 states, but even within the 2 states, FCT and Abuja, we cannot even generalize these results to the entire population within these states, because remember that we did intercept surveys, and these were at, major markets. So we just have to be careful not to generalize, to the entire population in Nigeria, but also to the entire population within the states. But they can provide context, to guide where to begin from. Thank you.
Yeah, and Lotus or Lynette, do you want to say something, or Francine? I see a question, for example, on when working with the younger target audience, we notice that teenagers are indifferent to COVID-19. Would opting for gender integrated messaging that piggybacks on other vaccines with less hesitance be more effective than directly referring just to COVID-19? And I think this question is looking, Lotus, I see you are typing, which is great, but I think also this question is trying to reflect on the relevance of our findings to other vaccines that go beyond COVID-19. And I think the 3 C's model about confidence, complacence, convenience is still extremely important to apply to the other vaccines. So lessons learned here, I think, can be useful as we also think about other vaccinations, because they might run into similar challenges around the 3 C's. Yeah, so I see another question here from Ms. Rank. I see the participants had a gender balance. Were you able to observe if there were any gender differences in the vaccine uptake or hesitance in the general population you were working with?
Yeah, so thank you very much for that question. Yes, we were able to observe some differences by gender. So for example, we noticed that more males were vaccinated than females. Thank you very much.
And I just wanted to add on that we also saw similar findings in the secondary data analysis, where there were variations by sex. And then it also differed depending on the round, but overall there were differences depending on differences between men and women.
Yeah, and I'll just add, there was differences also in the message effects arm of the study. In particular, we found that more women, in particular younger women, were using social media more, and that vaccine safety and efficacy were more commonly mentioned by women than men in both states.
Thank you so much. Our participants, and thanks for raising those very helpful questions. that have direct impact on the implications of these terms of informing other vaccinations that go beyond COVID-19. I would like to refer you to the reports that are on our websites that are being displayed right now. There you'll be able to get more information from the secondary data analysis report, from the research snapshots, from the exploring the role of message effects report. So from all these, you'll be able to get more information, including differences between the states, differences by gender, and how age is a factor, and how also location and geographies are factors. So we want really to thank you so much for being part of this. We want to thank you for keeping engaged. We want to thank all our partners that have contributed a lot to this, the entire consortium, but also Breakthrough Action for being a big part of this. Thank you so much. So I think with that, I want to thank everybody for participating and being engaged. And please, let's continue by making reference to these documents, reading them, and making the best use of them. Thank you. God bless you.